I've been asked to talk about when and how to use contrast in stress echo. Now, the when is very easy. The BSc guidelines on the use of contrast in stress echo, which will hopefully be published in the next couple of weeks, will state that if one segment is not seen well, before or after deep inspiration, you should administer contrast. The reason for this is that flow-limiting coronary artery disease can occur in one artery, and ischemia can manifest itself in one segment. Now, the more difficult question is how to use contrast to get good images in stress echo. I'm not going to cover the product preparation and administration. Benoit has already touched on that. But we will focus on the one thing that we have control over to get good images and often get wrong, resulting in very poor contrast images. Now, before I tell you what that is, I'm going to show you a few images. So as Benoit says, this is the real life, this is the real world. And I'm pretty ashamed to say that these images were acquired here in my center. Now, are these optimal images? Now, I probably don't need to mention why they're not, but we will mention it briefly in a minute. But let's first consider the indication for this study. Why are we doing it? Now, hopefully you can appreciate that there's some apical akinesis, even though the images are pretty bad, especially in 4-chamber, see a bit of apical hyperkinesis. And the clinical question here is there a thrombus? Did we answer the question by giving contrast and performing this study? We did not. We were definitely not able to rule out anything here. I mean, where to begin? You can't see the endocardial borders. We can't see the lateral wall. There's an awful lot of swirling at the apex. You can see that there's obviously a breathing artifact. The lateral wall disappears. The focus is all over the place. I mean, needless to say, you know, this is a non-diagnostic image, which brings us to the point that, you know, giving contrast, it's not the end all and the be all. We have to understand a little bit of the physics, the ultrasound physics, the bubble physics, and the machine physics to understand how the bubbles and the machine interact with each other and how we can manipulate this in order to get good images. Now, here's another question. Are these optimal images? The image on the left might be if we're making a volume or LVEF measurement, but it is not if we're looking for perfusion in the myocardium. So on the left, beautiful endocardial borders, epicardial borders, we can appreciate the thickening of the myocardium, but the image on the right allows for the imaging of the microbubbles within the myocardium. Now, the indication for performing this study is to rule out non-compaction. The image on the left is not ideal when looking for non-compaction, where the image on the right is. Now, on the left, what's happening here is that we are imaging at a contrast-specific low MI setting, and the spatial resolution is very high, and we're missing those very fine little trabeculations. Now, the study on the right was performed at an LVO setting, completely different ultrasound physics involved here, and it enables us to visualize those non-compacted myocardium much better. Now, I hope I've demonstrated how very different we can make contrast images look. And as I've mentioned before, the one constant in my experience is the contrast, the variable being the settings on the machine. And I might be contradicting Benoit here a little bit, and he's demonstrated, you know, how you can change things and, you know, change the depth and the focus and make alterations on your machine. And I'm here tonight to tell you that the new ultrasound algorithms, the platforms on the systems that we see in practice, both from GE and Philips, have really developed, and there's a lot of artificial intelligence and very clever algorithms that play in the background. And especially if you use the new systems with the latest software, and especially for the GE, although the machine itself hasn't changed, at the ESC this year they've launched their newest software setting, and I would urge you to get the latest software upgrades on your machines. Those days where we're used to have to tweak things and, you know, time gain compensation and depth and focus and compression, those days are over. You basically just have to use the presets. They're so sophisticated and so advanced that by changing these settings, you more often than not make the images much worse. So I'm very sorry, but we're going to just quickly look at some basic microbubble physics. Now, let's just remind ourselves, what are we trying to achieve by injecting contrast? We're trying to create a clear border between the tissue and the blood. Now, blood appears black on conventional 2D imaging because ultrasound scattered by red blood cells at conventional imaging frequencies are very weak, several thousand times weaker than signals coming from the tissue. Now, ultrasound coming from contrast bubbles come from the scattering of incident ultrasound at a gas-liquid interface. And this interface is obviously the bubble in the blood. And this increases the strength of the returning signal. Now, let's quickly remind ourselves of what contrast is. It's purely a microbubble, acoustically active, gas-filled microspheres. And in the case of SonoView, the bubble is a shell made of a phospholipid that contains an inert high-density gas called sulfur hexafluoride. Now, contrast imaging techniques are trying to detect the echo coming from the microbubble while at the same time suppressing the echo coming from the tissue. So that's why the tissue always looks so very black, because these techniques are actively trying to suppress the signals coming from the myocardium. Now, remember, microbubbles emit non-linear signals because they're oscillating, while tissue mostly emits linear signals. It does to some extent also emit non-linear signals because tissue does also compress in the field of ultrasound, but it's mostly linear. Now, microbubbles in a beam of ultrasound undergo resonant oscillations due to the variations in the acoustic pressure that's being transmitted by the transducer, as you can see in this image. While they oscillate, the microbubbles are stiffer when compressed and less stiff when expanded. And this causes the radius of the bubble to change asymmetrically. And then the reflected echoes containing the nonlinear components, called harmonic signals, will be picked up. And we're all familiar with harmonic imaging. It's the default imaging for all our standard transthoracic imaging. Originally, methods of bubble detection consisted of harmonic imaging. It was a bit of a fluke. They experimented with bubble physics, and this is how they pretty much stumbled upon harmonic imaging. So what happened was they discovered this harmonic, the second harmonic, and then it was collected and filtered from the receiving signal. Now, this worked because microbubbles generate a much larger second harmonic signal than tissue. But the problem with imaging contrast at a harmonic frequency is that it requires a relatively high mechanical index. And any of you who've ever injected contrast and have not gone to your low MI setting, there's an awful lot of bubble destruction. And this high MI will destroy and eliminate most of the contrast. And it makes it pretty unsuitable for real-time contrast imaging. Now, I'm almost done with the boring stuff, and then I'm going to show you what it looks like in the real world. Now, the two most important contrast-specific techniques are pulse inversion and that works with harmonic imaging and power modulation. So basically, what we need to refine contrast imaging is tissue cancellation techniques. So with tissue cancellation techniques, and you'll be most familiar with this is the contrast low MI setting as it's labeled on the Philips platform, and this is typically multipulse tissue cancellation technique. It uses a very low MI, usually between 0.5 and 0.2, and it is a multipulse cancellation technique. So what happens, multiple pulses are emitted down the scan line of the image, and the pulse, the power, the amplitude of each pulse is varied, and then the lower power pulses create a linear response, where the slightly higher power pulse results in a linear response from the tissue. but non-linear from microbubble. And the linear responses from the two different pulses are then subtracted from each other, and the transducer only detects the non-linear behavior. I think you've all seen this picture before, and that's basically under the hood, very clever algorithms that's going on that we basically don't have any influence over. So how does this look in the real world? So this is a default harmonic image. And how do we know it's harmonics? Because of these little symbols over here. Actually, here. So this is how we know we're in harmonic imaging. So this is the second harmonic. So the pulse is sent at a frequency of 1.8, and the second harmonic is double the frequency of the pulse that was sent. And also this is a high mechanical index. And you can see that, you know, it's very bright. You can see the signals coming from the tissue beautifully, and there is no harmonic, or the harmonics coming from the signals from the blood is very weak. That's why it looks so black. So this is on the Philips machine, and we'll quickly look at the GE machine as well. This is your standard preset for contrast imaging on a new Philips system like the CVX. Preset, you basically choose your transducer. In this case, this is a 3D probe. In theory, a 3D probe should destroy the contrast more than a 2D probe because there are so many more scan lines. But I'll show you examples of a 2D probe and a 3D probe side by side, and it doesn't always make sense. Our advice is always to try and image with all your probes and see which one gives you the best images. So what settings, what physics is going on here? So at an LVO setting, we are imaging, this is default, I've not changed a single thing here. The default MI is 0.3, so this is considered an intermediate MI. Just for reference, anything above 0.5 is considered a high MI. Anything between 0.2 and 0.5 is an intermediate MI, and anything less than 0.2 we would consider as a low MI. And so this is probably a single pulse technique, and we are still in harmonic imaging here, and that's why you can see the myocardium is nice and black, suppressing the signals coming from the myocardium, but there is a lot of swirling at the apex here, and that is because we are still at a relatively high MI. Now the next contrast setting we have, and this is where the multi-pulse, the tissue cancellation techniques come in. So when you hit the preset on the machine contrast, low MI, what happens, it automatically defaults to a low MI, so anything less than 0.4, and this is happening at a fundamental frequency, and we can see here that the second harmonic is turned off, and that's why we can see bubbles in the myocardium. So different settings is required for different imaging. If you're not particularly interested in myocardial perfusion, there's a very good case for using the prior LVO setting. However, here you can see beautiful homogeneous opacification. There's as much contrast in the near field as the far field, and what the advantages of this imaging technique, over and above the fact that you can assess wall motion and myocardial perfusion, is that you will use a very small amounts of sonoview. It will hang around for a very long time because you're not destroying the bubbles. So very small volumes of contrast needed here, and very few imaging artifacts. Now you can see there's a little bit of blackness here, and I'm sure I'm going to get a question, but if you to move the focus up to the apex, you would get rid of this blackness. It's just the focus will concentrate the beam of ultrasound right at the top, and it will increase the resolution of the image. So I could have improved this image by moving the focus up to the apex. Now, this is an old IE33, my favorite, and this is how very different you can make images look. So this is the same patient, this is the same contrast, and I've just basically messed around with the settings. And that's why it's so important for you to understand the physics of the settings, because what's happened here is this is a regular LVO setting. You might not be able to see the mechanical index here, but it's above 0.3. We're in harmonic imaging, and yeah, little swirling at the apex, can't really see the lateral wall very well. That might just be an imaging issue. And what's happened here is that I've just basically manually turned the mechanical index down. So a lot of often, you know, you hear low MI is good, but you must remember that by simply turning down the MI, you're reducing the power and you'll get much worse images. So if anything, you should turn the power up because the signals will be much better. But the trade-off will be that you'll be destroying the contrast. So in my experience, you honestly do not have to adjust the mechanical index. If your machine is optimized, all you need to do is use the presets as indicated. This image here is a little bit of a tweak. Basically, it's an LVO setting, and all I've done is I've turned the harmonic off manually. I've just gone down to fundamental, and then what automatically happens is the mechanical index will drop down to a low MI, and by turning off the second harmonic, you can't really appreciate it in this image, but you'll start seeing microbubbles in the myocardium. But by dropping the mechanical index here, also you can see, I mean, these aren't the best images, but the opacification is a lot more homogeneous. There's a lot less swirling at the apex, and it looks much better than the image at the top. And then lastly, this is your low MI preset. Also not the best image, but you can appreciate how much brighter the contrast looks in the LV cavity. Like I said, presets, a lot of fancy, clever algorithms going on in the background. And by changing anything, you are going to make it far worse. This is a multi-pulse tissue cancellation technique. Like I said, lots of clever stuff going on under the hood, but the telltale sign here is that we are operating under a fundamental frequency. This is just also an example of a more modern system. This is the CVX. This is a 3D probe. Again, same LVO setting, intermediate MI, harmonic imaging, nice black myocardium if that's what you like, a nice clear, crisp endocardial borders, but there is a bit of swirling in the apex. So this is my little cheat. What I do is I'll stay in an LVO setting and I'll just basically turn off the harmonic. I'll make it fundamental. Automatically, the MI drops down to a low MI, and there's a lot less bubble destruction, nice homogeneous opacification, and you can already start seeing the bubbles in the myocardium. And if you're interested in perfusion, this is your low MI setting. There it is, less than 2. We're in fundamental frequency here, and beautiful opacification, and you can see the bubbles in the myocardium. And as I've said before, you'll use very, very small volumes of contrast, and there'll be hardly any artifacts. Now, this is the same patient, the same contrast, the same machine, but it's a different probe. I hope you can appreciate how very different it looks. Now, this is a 2D probe. And in theory, the 2D probe should give you better images. But in my center, we have 9 CVX systems. No 2 are running at the same software version. Some have had upgrades. And no 2 probes are the same. Apparently, the altitude at which the piezoelectric crystal gets forged will change the probe. So in my experience, that machine and that probe, you have to hunt for them, magic combination, make that your contrast station, and don't mess around with it because it really does make a difference. And then on my next slide, I'm just going to show you side by side what the 2 probes look like. This is the same setting. This is the same machine, same patient, same contrast, 2 different probes, and it looks unbelievably different. And that's why, in my experience, you know, if you get images like this, you might say, oh dear, there's something wrong with the contrast. Give me another batch. Let's make up another vial. Give me more, give me less. It's really just as simple as trying a different probe. This is just to show you the presets. This is on the Philips CVX system. So how do you activate these presets? You choose your transducer, S5, X1. You go to contrast, LVO, or low MI. Yeah, I would, if you've never tried low MI before, you don't have to be particularly interested in myocardial perfusion, but I would suggest that you try it. This is what the GE presets look like, typically on your E95 also a range of probes that you can choose from, and this is a 4D, 3D probe. I think this is a 2D probe. And these are the different contrast presets. You have LV contrast and LVO stressed, contrast low MI. And I'll just briefly show you what that looks like. This is an image of an LVO contrast setting. So it defaults to an intermediate MI. And I think it is the tissue cancellation technique at play here is pulse inversion, and I might be able to convince you that there's a little bit of swirling at the apex, but nice homogeneous opacification, really, really good images. And then the other GE contrast setting is called LVO stressed. Now it looks a little bit different. I hope you can appreciate it. It looks a little bit softer. It's not so crisp. And the reason is because this has been designed to capture images at higher heart rates. So it has to contend with higher frame rates. This is why there's a little bit of a compromise here. The images are still pretty good. You can see a little bit of swirling at the apex. And this will typically also be at an intermediate MI. Pulse inversion at play here. It just looks a little bit softer. And then this is what a low MI, oh, here just side by side. I don't know if you can appreciate it, maybe just a little bit on the right. You can see some scan lines here. So there is a little bit of compromise in the quality of the images. And as I said, it's just because it's designed to capture at higher heart rates. And then with GE, there's a nice function. There's a lot of post-processing. So once you've taken the pictures, it's a bit like using a photo editor app on your phone. You can change all sorts of things to make it look a little bit crisper, but the secret is not to overdo it. You can lose some of the definition. And this is what the contrast low MI looks like on the GE system. And unfortunately, it's still being developed. Professor Senior and myself have been working with the guys in Sweden to try and optimize this. So we don't currently recommend that you use the low contrast MI setting on your GE system. So yeah, hopefully this is really, I suppose, what we're all aiming for. Some beautiful contrast images here. You might argue that it's a bit oversaturated here. This is a low MI setting where some contrast in the septum. But yeah, at the end of the day, this is a Philips system, what we're aiming for. And on the GE, at the end of the day, yeah, the kind of pictures that we all should be aiming for. Thank you very much. That's me all done.